congratulations. And I am waiting from Nation Taiwan University Hospital Beijing branch. Now, for the injections, only for the fingers regions. So we separate as the target for the injection. For example, the dorsal side we will injection for the extensor and for the flexor tendon. You can also perform injection. So you can see I separate as the flexor as a tendon, ligaments, and the joint or muscle. So separate to each. For example, the tendon you will decision where is the tendon injury and where is the tendinosynovitis, and then you can choose to use the steroid or the dextrose or even PRP. But for the ligaments, we easy to neglect the annular ligament and the surrounding tissue, the retinaculum. So I will give a quick talk for the so many structure. But for example, you can see for the tendinosynovitis, they will also happen on the wrist. So for example, you can see the synovium is around this region. So this is target you should perform the ultrasound examination first and then to find where is the lesion. But for the more distal, then you can check where is the injury for the essential tendon. For example, the central stick or the terminal band. Go to the palmar side again. We neglect the carpal tunnel syndrome, but we will see the most common happen will be the trigger finger and even the trigger thumb. Then we will go through to the radial or ulnar collateral ligament. So before you perform the injection, you should know what is the image in the ultrasound for the needle. For example, we like to perform the so-called long axis view, or you can call it implant approach. So if you use the implant approach, you will see a hypercoiled needle, and posteriorly to the needle, you will find so-called the common tail, the reverberation from the mallet. So this is a target to find the needle. And as Professor Kevin mentioned before, the most important we will make maybe the deformity syndrome. So you can see the tendon sheets become swelling. But before we perform the injections, the most important structure will be here. Not the artery, it will be, this is the superficial radial nerve. Because the dorsal lateral branch of the superficial radial nerve will go through the first compartment first. So if you want to perform the injection, you should check where is the dorsal lateral branch of the superficial radial nerve and the dorsal medial branch, and then you can perform the injection to the tendon sheath. And then you can check the tendon from the proximal side and the distal side. For example, if you use your transducer go to the more proximal side, you will make the so-called proximal intersection junction. It means the first compartment will cross over the second compartment. In some case, for example, you can see the tendon sheath become swelling and increase blood flow. So this is the proximal intersection junction, maybe due to the irritation and become inflammation. And again, just focus on the external carpal longus and brevis tendon and go through to the distal side. Then you will meet the distal intersection junction. For example, you can see also very beautiful, you can find the tendon sheath, even the external brevis longus and the external ECRP and ECI become swelling and hyperemia. So you can choose for like this, you can use the injection. So you can see this is a needle and you can see the common tail below it. So then you can push the injectant. For example, I push the steroid to treat the patient. And the extensor distal community tendon is the most common, is very common in the dorsal side. So for example, you can see this is rheumatic arthritic case. So you can find the venous accumulations in the joint. And around it, you can see above the dorsal radial ulnar joint, you can find the swelling extensor distal community tendon and the swelling sheath. And another case, you can see the effusion around it. So if you want, use the injection and not punch through the tendon, you can make the injected around the posterior interosseous nerve or just in the tendon sheath, but not punch through the tendon itself. The extensor carpal ulnaris tendon for near the TFCC, also sometimes you will find the tendinosynovitis. For example, you can see very clear the tendon sheath becomes swelling and increased blood flow. And this is long axis view, you can see very beautiful, and even the ulnar collateral ligament of the TFCC is become become swelling and hyperemia. But before you perform the injection, for example, you can see this is a tendon tear. So for this case, I will not choose the steroid because some doctor will mention maybe the steroid will let the tendon become more fragile. So maybe the delayed tear will happen. So for example, maybe you can choose the PRP or the dextrose to treat such case. The flexor carpal radialis tendon is near the carpal tunnel. It just superficial to the scaphoid tubercle. So you can see this is a normal FCR tendon, and this is the insertion site. But for this case, you can see become hyperemia and the surrounding, you can find even some synovium accumulated here. So if you use the Schultz's view, you can see very beautiful. The flexor carpal radialis tendon is surrounded by the hypoacute region. So for such case, maybe you can choose the steroid, for example, like this. Very easy. You can just put your transducer on the scaphoid, and then you will quickly find the flexor carpal radialis tendon just tap on it. So then you can perform the implant approach, very safe and will not injury to the surrounding tissue. Then we go through to the more difficult structure is the essential tendon because it's more small. So you should use the Hockey transducer or high frequency, maybe 18 megahertz. So you can start from the metacarpal joint and go to the more distal side. For example, you can see this is the essential tendon. And if you check the fiber more distally, then until to the middle and base of the middle phalanx, then you will get the central sleeve insertion region. But if you want to check the terminal band and the lateral band, you should go back and start from the nail. So you can find the nail matrix and use your transducer through back. And then you can quickly get this is a terminal band and ulnar or radial side lateral band. But you should be careful because about the terminal band and lateral band, this is a triangular aponeurosis and then artery is located in it. So if you want to perform the injection, you will wonder, should I injection from the proximal to the distal or from the distal to the proximal? So for example, this is the case you can see very clear. This is in the central sleeve insertion side, this is the proximal phalanx, this is the middle phalanx space, and you can see the insertion of the central sleeve become very swelling and increase blood flow. And the fiber, maybe you can say maybe a little partial tear because you can find some hypoacute cleft in it. And for the middle finger, the terminal band injury, you can see I go through back from the nail, and you can see the terminal band become very swelling and beautiful. So you can perform the dynamic examination to check if the tendon is totally tear or only partial tear. So you can see if I want to perform injections for the terminal band, I like to injection through the distal to the proximal side, just above the nail. It will be very pain, but so you can perform the nerve block first and then perform the injection with the PRP. Why? Because above it you can see this is not injected, this is the artery. So if you want to injection the terminal band, I like to perform injection from the distal to the proximal side. But for the central sleeve, because no artery above the central sleeve, so for this case, I injection from the proximal side to the distal side so injection the insertion of the central sleeve in the base of the middle phalanx. So for this case, I use the PRP to treat the partial tear of the essential tendon tear. And then we go to more simple region is the ligament. The ligament is the most common is the so-called trigger finger because the pulling is the annular ligament. So this is A1 pulling, and I like to perform the injection through the lateral or medial side with the implant approach, and then lay the needle tip just between the flexor tendon and the retinaculum. If you want, you can use the implant approach or with from the proximal to the distal or distal to the proximal. It's okay. That depends on you. For example, you can see you should turn up a power and you can find the hyperemia around the annular ligament, and then I like to perform the injection. But before you perform the injection, you should be careful because you can see some artery, common digital artery and common digital nerve is beside the flexor tendon. So the most important is not only find the needle tip and find the target, you should check where is the common digital artery and where is the common digital nerve, and choose the course for the injection, and then perform the implant approach. And finally, we will go to the extensor side to check the extensor hood. So you can see this is sagittal band from the lumbricolis muscle, dorsal interosseous muscle, and you can see this is extensor tendon, and this is sagittal band. And you can see very clear, you can find the extensor hood becomes swelling and the hyperemia. Beside, tip to the structure, you can see also the collateral ligament become very swelling and the increased blood flow. So for this case, I perform the injection with a steroid, but I do not want to pump through the tendon. So I go to tip and injection from lateral to the medially, and both make the injection around the sagittal band and the radial collateral ligament. So you can see this is the proper collateral ligament, and this is the accessory collateral ligament. So I perform one shoot and to treat the three structures to treat the pain. And the extensor retinaculum, you can, where is the extensor retinaculum? If you want to check it, you should start from the distal tubercle. So when you find the distal tubercle and pull the transducers more distally, then you will see some hypoacute fiber cross over the extensor community tendon and over EPL and the extensor brevis. So if you use the long axis view, you can see this is the extensor retinaculum. This is the case suffering from the radius collis fracture. So you can see the retinaculum become a little swelling and the fiber is irregular. So this is the fracture side, and you can see the retinaculum become a little irregular and hypertrophy. So if you want, you can perform some injection on the retinaculum. The collateral ligaments is, as we mentioned before, you should make the patient to gently flex the finger, because when you flex the finger, you will make the fiber become more tight and more clear. So you can see this is a little sprain, maybe a little partial tear in it, and you can turn out the pulse very beautiful. You can see the blood flow increase, and then you can injection. So how to perform injection? First, you can use the outer plane, but you can see, if you use the outer plane, you will only see one hyperacute duct, and not easy to control the needle tip. But if you want, you can also perform the long implant approach. You will see, if I use the implant approach, then you can see the whole direction of the needle, and you can perform the, for example, now this is injection for the joint, and you can retro back to make the injection around the radial collateral ligament. So as for my experience, it will be more safe to perform the injection than the outer plane. The last, I will quickly talk about the muscle. So the lumbricolis muscle is the real injury regions. For example, you can see this is the flexor tendon, FDS FTP, and this is the normal side. You can see this is lumbricolis muscle. This is common digital arteries. And you can see this region, you can find some hyperemia in the muscle bellies. So you can perform the long axis view, you can find the lumbricolis muscle is injuries. And for this case, I perform the steroid injection. And this is a different case. I perform the focus injection for the head upper limb. So how to perform the injection to treat the lumbricolis muscle? So you can see I injection from laterally and go to the from the medial side to the lateral side, and you can treat the adductor aponeurosis first and adjust the angle. You can see I treat the lumbricolis muscle and adjust the later. I will adjust the angle more deep to treat the adductor aponeurosis muscle. So you can see this is the needle tip is in the adductors, and you can also push some in focus injection, and then adjust the angle to go through more superficially. And then you can see this is you can see I adjust the angle and to treat another side of the lumbricolis muscle. So this is the very easy to perform the lumbricosis muscle injection than the autoplane. Because if you use the autoplane, maybe you will puncture the flexor tendon and induce some injury from the surrounding tissue. So for myself, I would suggest you to perform the implant approach. This is the lesser target. So for example, we will see this is the CMC joint. This is normal case. You can see you can see this is osteoarthritis. You can see the inflammation, and this is psoriatic arthritis. You can see the bony erosion around the bone. So and some synovial accumulation, and the ligament it becomes swelling. So for such case, then you can injection through the proximal to the distal side and injection the CMC joint. But before you perform the injection, first, the most important is you should find where is the radial arteries. Because if for the injection for the CMC joint, the most important is to check the artery. So if you can find the artery, then you can set and perform the implant approach. So this is the latest